This is our third and final series on chronic pelvic pain. Today's talk is on Vulvodynia, Vestibulodynia. We'll go into the diagnosis, treatment options, and current new treatment modalities. Chronic pelvic pain is having pain within the pelvis for more than 6 months. And in defining Vulvodynia and Vestibulodynia, it's the presence of vaginal pain for 6 months or longer. The two distinguishing factors of Vestibulodynia versus Vulvodynia. Vulvodynia means the presence of pain within the vulva, which is the entrance to the vagina, where pain is not supposed to be, whereas Vestibulodynia is the presence of pain within the vestibule, which is the space between the vagina and where the hymen is. Vulvodynia by itself has a prevalence of about 15%, and it's across age range from young women, typically up until the older age group. It typically presents with pain within the vagina, and for some other patients, they describe rawness and the entry of the vagina, or pain due to intercourse. Typically, is described in younger women when they start to use tampons in the vagina and they have a harder time with the insertion of tampons. Other symptoms that patients with Vulvodynia will describe would include itchiness at the vagina, the entrance to the vagina, and that typically occurs with vulvodermatosis, which we'll save for another talk. Vulvodynia is described as either localized as in a specific spot, typically at the 6 o'clock spot if you look at the face of a clock, or is generalized when it's all around the entrance to the vagina. It is also described as provoked, which means pain only with intercourse or insertion of a tampon, or else it's unprovoked, where it is progressed from the point of nothing being inserted to a constant pain. It is also described as intermittent versus a constant pain. It is thought that the cause of Vulvodynia is multifactorial, which involves inflammation and also nerve fibers that are firing off, which is a neuropathy, and it's also thought to be under hormonal influence. The diagnosis is typically made based on a history and a physical exam. However, it is also known that prior to patients presenting for the first time being diagnosed with Vulvodynia, younger women are typically thought to have candida vaginal infection, where they have a burning sensation and have been treated in the past with antifungal treatment several times by different providers without any relief. Examination typically involves a Q-tip exam to the entrance to the vagina. Allodynia is perceived as pain at the entrance of the vagina, where pain is not supposed to be present, just with pressure with a Q-tip to the entrance to the vagina. In addition, though, patients who have Vestibulodynia will have redness to the entrance to the vagina or fissuring at the entrance to the vagina. It is thought that treatment is always multimodal for every chronic pain condition. Vagina has a lining, which is a vaginal epithelium. Underneath the lining of the vagina are nerve fibers, and underneath that are muscles. And this is very important when it comes to treatment. Treatment involves medication, pelvic floor physical therapy, and there's adjunctive therapy in the form of a trigger point injection, which we'll go into in a minute. However, in medical management involves the use of oral medication, which will be neuroleptics, which are medications to stop the nerve fibers from firing off, which is the constant burning that patients with Vulvodynia get. However, local treatment with a compounded cream, its constituents will be estrogen, which is for the lining of the vaginal epithelium. Nerve fibers will be a neuroleptic, which will include amitriptyline. There's a use of lidocaine, that is to help numb the nerve fibers at the entrance to the vagina. And there's also sometimes the use of a muscle relaxant if there's an element of pelvic floor muscle spasm associated with the Vulvodynia. The typical treatment would be application of a compounded cream to the entrance to the vagina once daily. And with time, the nerve fibers start to damping down, and therefore patients stop to experience vulvar burning or pain. There is the role for pelvic floor physical therapy, which helps with nerve fibers being relaxed and therefore incoordinately firing off to give the pain and burning associated with Vulvodynia. There is also pelvic floor physical therapy to help with relaxation of the muscles to the entrance of the vagina. There is adjunctive therapy, which is the use of trigger point injection. There is one medication that has been randomized and has been found to be effective and is used in Vulvodynia, which is the use of Botox. Believe it or not, Botox helps the pelvic floor muscles relax. And as a result of that, muscles stay relaxed and helps the vaginal introitus to be relaxed. There are newer treatment modalities that we've used in the last year, and it's the use of regenerative therapy to the vulva. Regenerative therapy involves cells that are harvested from amniotic fluid, which have regenerative potential, and it is thought that by the injection of regenerative cells to the entrance of the vagina, it helps with nerve fiber regeneration and therefore stops the incoordinate nerve fibers from firing off, which results in the burning and the pain associated with vulvodynia. These are early phase studies where regenerative cells are being used in the entrance of the vagina. However, significant results are seen within 6 weeks after initial injections. Lifestyle changes are very important, and in the next series, we will talk about other treatment modalities that are currently being investigated for the treatment of vulvodynia or vestibulodynia.